Welcome, everyone, to our monthly Lunch and Learn. I'm glad to see so many faces here. We've got Mark Niciu with us today from the university. He's going to talk about psilocybin and its use in psychiatric disorders. So let me tell you a little bit about Mark, although this bio, there's no way I can do it justice. He
Mm.
is currently an assistant professor of psychiatry at the university. He got his BS in biology and philosophy at Manhattan College in the Bronx, in New York, and his medical degree at the University of Connecticut Health Center in Farmington, Connecticut. His PhD is from the University of Connecticut Health Center, and he did his fellowship in neuroscience research, and that's at Yale. And he was also the chief resident in psychiatry at Yale. So he's done a lot. He's really interested in the pathophysiology and experimental therapeutics of major mood disorders, particularly glutamate and sub-anesthetic dose ketamine in treatment-resistant major depression. In fact, Mark was on earlier at a lunch and learn for us to talk about ketamine. So welcome, Mark. You have a wealth of experience and knowledge about this topic, and we appreciate your coming on today.
Thank you so much, Joanna, and I appreciate the invite. Yeah, so this is a relatively new topic for me. I've started working with psilocybin, like several other investigators who study experimental therapeutics in major mood disorders in the past few years. So I've learned a lot about the topic. It's fascinating, and you'll see the intersection that we've paved with ketamine later. But yeah, my expertise typically has been with glutamate-based treatments, especially ketamine, racemic ketamine, intranasal S-ketamine. But this is a new direction and focus that I'm particularly excited about. So, and thanks again for the invite. So I have no conflicts of interest to disclose. So I have two learning objectives here. So I'm going to describe some of the existing evidence supporting the use of psilocybin in the treatment of psychiatric disorders based on my particular interests, as well as preponderance of data in certain areas. I'm going to talk about three disorders in particular, kind of a cursory overview of those three: major depressive disorder, MDD; bipolar disorder, which I'll abbreviate as BD throughout; and alcohol use disorder, or AUD. And then I'm going to hopefully have enough time to introduce you to two randomized controlled trials conducted at Iowa comparing psilocybin-assisted psychotherapy and ketamine-assisted psychotherapy for alcohol use disorders. So this is the outline. So I'm going to give a very brief introduction just so everybody's on the same page. I know people are probably extremely familiar with diagnostic criteria and standard treatments, but just humor me for a little bit. So major depressive disorder, bipolar disorder, and then also a little bit about alcohol use disorders. I'll talk about psilocybin, pharmacodynamics, mechanisms, again, its use in the treatment of these conditions. Ketamine, I'm going to just really quickly introduce it. Again, there's another talk that I gave fully on ketamine that's, I know, on the YouTube page. So feel free to refer to that if you like, and then talk about these clinical trials. So major depressive disorder is on the left here. So this is the criteria for a major depressive episode. And it's at least 2 weeks of the following symptoms. So 5 of 9. The two that are mandatory, one of the two that are mandatory are the ones in red, or red, depressed mood and decreased or loss of interest or anhedonia. But the kind of common mnemonic that you learn in med school is SIGI CAPS, and I highlighted those there. So changes in sleep, feelings of guilt, decreases in energy, changes in focus, concentration, changes in appetite, and suicidal thinking. And in order to meet criteria for major depressive disorder, it has to be not better explained by alternative conditions. So kind of a classic condition that can masquerade as MDD would be hypothyroidism, or be attributable to substance use or withdrawal, for example, alcohol use disorder or a stimulant withdrawal syndrome. And it must cause functional impairment. That's another mandatory criteria. So you could have these symptoms, be very highly functioning, and you would not necessarily be criteria for MDD. So bipolar, you could obviously bipolar, there's two ends of the spectrum there. There's the depressive end and the manic or hypomanic end. What I'm presenting here on the right is at least 1 week in bipolar 1 or 4 days in bipolar 2 of the following manic or hypomanic symptoms. One of the things that's mandatory, again, is elevated, expansive, or irritable mood. And then the others are, there's a mnemonic called dig fast. So distractibility, impulsivity, grandiosity, flight of ideas, or racing thoughts, usually an increased activity. And one of the things that's particularly pathognomonic for bipolar disorder is a decreased need for sleep. And oftentimes it's kind of the canary in the coal mine for the onset of a manic or hypomanic episode, where people notice that they have a decreased need for sleep. And then talkativeness. And again, not better explained by alternative etiology. So in this condition would be hyperthyroidism or substance use or withdrawal. So for example, a stimulant intoxication syndrome. And again, must cause functional impairment. So there's a great need for novel treatments for major depressive disorder and for bipolar disorder. The top of this slide here is I'm going to talk about 2 real-world studies in major depressive disorder, and in the bottom, as you can probably tell from the descriptors, these are 2 real-world studies in bipolar disorder that demonstrate that critical need. So one is a very large, famous study called STAR-D, or Sequence Treatment Alternatives to Relieve Depression. Had about 3,000 subjects. It was an all-comer study, multi-site, and everybody was randomized to citalopram as the first-line treatment. And about 1/3 of those patients had remission with citalopram only. 1/3 of the patients had a response, usually defined by a 50% improvement in depressive symptoms, and 1/3 of those patients had very little to no response at all. And for the patients that had minimal response, there was subsequent arms of the trial where they could be randomized to different forms of therapy, other medications, augmentation strategies in combination, all the way down to the final step, which was electroconvulsive therapy. And as you can guess, the more treatment resistant you were, the worse the outcome from both a symptom standpoint as well as from a functional perspective. One of the things that also gets proposed is, if we, kind of the American way that, more is better. So is it better to combine antidepressants right off the gate, right out of the gate? So somebody comes in with a major depressive episode, instead of just trying one medication, like for example, in diabetes, you might, depending on somebody's hemoglobin A1C, you might put them on more than one medication right off the diagnostic. But when this was studied with major depressive disorder in this co-med trial with 665 participants, there was no difference whether you were randomized to one antidepressant, escitalopram or Lexapro, plus placebo, versus pretty typical augmentation strategy with bupropion or Wellbutrin, and then a combination of venlafaxine and mirtazapine. So there was no difference whether you got 1 or 2 antidepressants, and really no difference between the combinations thereof. In the bottom slide, bottom part here, we're looking at the kind of equivalent to STAR-D for bipolar disorder, was called STEP-BD. And in this study, again, multitude of different treatments were used, including lithium, valproic acid, and combination therapy was used. So oftentimes in bipolar depression, people will be on a typical mood stabilizer, so something like lithium, lamotrigine, and they'll also be on an SSRI or SNRI-based antidepressant. And when people were on those 2 medications, it was really no different than being on just a mood stabilizer plus placebo. There was no change in durable recovery. And then this one particularly sobering, because we think, this historically has been one of our best treatments for bipolar disorder, lithium, at moderate doses. So when lithium was combined with standard outpatient treatment versus a placebo with standard outpatient treatment, meaning psychotherapy, other functional supports, group therapy, there's no difference in functional outcome. There were differences in symptomatic improvement, but unfortunately, there was really no difference in people's ability to function at the level that they so desire in their everyday lives. So again, a critical need for novel treatments. But before we go on to one of those potential novel treatments being psilocybin, which I'm hopefully setting up, we'll talk a little bit about alcohol use disorders. So this is the second most prevalent substance use disorder after nicotine use in the United States, as well as worldwide. Very high prevalence. High disability due to psychosocial dysfunction, legal ramifications of alcohol misuse like OWI, medical complications, so multifactorial medical complications, cardiovascular, hepatotoxic, central nervous system. There's potent toxic effects of alcohol when used in long term. And there's really like major depressive disorder, like bipolar disorder, relatively limited treatment options, and they all have a small to moderate effect size. We'll look at some effect sizes a little bit later, and high relapse rates. But the kind of standard of care for the treatment of alcohol use disorders historically has been 12-step based programs. But in our realm, psychotherapy, cognitive behavioral therapy in particular, or CBT, motivational enhancement therapy or motivational interviewing, MET or MI. And then there's a few medications that have been approved. So these are the FDA approved medications. There are some that have been shown to have efficacy off label. Disulfiram, naltrexone, and acamprosate are the three that are approved, but some other ones like topiramate, gabapentin have shown efficacy in certain studies. So again, there's a critical need for novel interventions with alternative or more experimental mechanisms of action. So one of these pathways has been the study of psilocybin. So I'm not going to talk really about the history of psilocybin. I'm going to keep it very focused on the pharmacology here, but we can talk about that in the Q&A if you so desire. But there's a ton out there already about the use of psilocybin in the 60s. It's how it was outlawed in the United States for almost 20, 30 years, and it's kind of rebirth in the early 2000s into the present day. So this is what we would consider to be a classical psychedelic. So the classic psychedelic is LSD, or lysergic acid diethylamine. But any of these medications that are serotonin receptor or 5-HT2A agonists would be considered a classical psychedelic. So other things that you might have heard of are DMT or dimethyltryptamine, mescaline. Oftentimes this is used in First Nation religious ceremonies. There's others too, but these are anything that's a 5-HT2A agonist would be considered a classical psychedelic, in contrast to ketamine, which we'll discuss. So psilocybin is a hallucinogenic alkaloid of the psilocybin mushrooms, and people use the term magic mushrooms. It was historically part of many religious ceremonies or other events. And I'll talk about toxicology because, as with anything, the dose really becomes the poison here. So at very high doses, psilocybin can cause significant psychotic symptoms, can cause dissociation, so disconnection from reality, disconnection from self. Sympathomimesis, meaning it can increase your blood pressure, increase your pulse to dangerous levels. And one of the things that is kind of known for is causing nausea and vomiting. And in some circles, that's considered kind of part of the purge of the psilocybin experience, is the induction of vomitus. So thankfully, it's rarely lethal in isolation. So it can have, profound sequelae on the central nervous system, but it doesn't cause respiratory depression, for example, like an opiate would in intoxication. And it's still Schedule 1, so meaning that there's no known therapeutic status. Other things that are Schedule 1 would be like cocaine. But the FDA granted this breakthrough status for subsequent investigation by researchers in late 2019. And a lot of the research that I'm going to present here, I think exclusively, has been since that breakthrough status was granted. So I'm going to talk about two pivotal trials for major depressive disorder, an open label trial for bipolar, and then two trials for alcohol use disorder. There's a lot of information in these slides, especially from the demographics table. And, thankfully this is being recorded. So if you wanted to go and refer to that later, but I'm also, if anybody wants to email me, I'm happy to share my slides as well. So there have been two major producers of psilocybin in the United States. One is called Compass, company is called Compass, and the other is Usona. So this study was sponsored by Compass. The name of their compound is Comp360, but it's a synthetic psilocybin, and they studied it in treatment-resistant MDD. So the reason why I put placebo in quotes there is because they were really using what some people would consider to be a microdose as the placebo. So it's a pretty interesting design here, things just to draw your attention. It's a relatively large study, a multi-site study. The subjects received one of 3 doses of psilocybin, 25 milligrams, which is now kind of the standard dose used in the field for psychiatric purposes. 10 milligrams, kind of a modest dose, and then 1 milligram, which would be the kind of, extremely low dose or microdose of the compound. Just to draw your attention to, I think, a few things that are pertinent here. This was a relatively treatment-resistant population. Many of these patients failed at least two, if not more, antidepressants in their current depressive episode, and that their severity was what we would consider to be moderate to severe for the most part. The average mean Montgomery-Åsberg Depression Rating Scale, or MADRS. You'll see a lot of slides in here that use MADRS as the primary outcome for the trial. It's a clinician-administered 10-question depression rating scale. And anything considered above 30 would be severe, moderate, 20 to 30. So you see it's about majority of patients were in that severe range across all treatment arms. And HAM-D is another, the Hamilton Depression Rating Scale, another clinician-administered depression rating scale, again, indicating primarily moderate to severe depression in this cohort. All right, so they had three arms here. The primary outcome here was at week 3. So subjects came in for their baseline visit, and all of these studies too, I'm not going to really talk much about it, but they had a significant psychotherapeutic component. So they were prepped for the psilocybin session. They were in the presence of a psychotherapist or a team of psychotherapists during the psilocybin administration itself, where they talked through what they were experiencing. And then they had subsequent visits with psychotherapists where they processed the experience. So the assisted psychotherapy is a major component of all of these trials. But I'm not going to really focus on that per se here, but just to be mindful that's running in the background of every study that I'm talking about here, including ones that we're doing. So at week 3, you see that there was the bottom line here is the high dose of psilocybin. The lighter green is the middle dose, and then the low dose is the kind of, I guess, forest green, darker green or gray. Depends on your screen how it looks, but you see that there was a clear separation at week 3, with 25 milligrams being superior to the other 2 doses, and especially more efficacious than the 1 milligram dose. However, the 10 milligram dose did not separate from the 1 milligram dose. And what's pretty interesting, you'll see in a lot of these slides, this is a single administration of a drug. Of course, they're getting extensive psychotherapy during the trial, but out to 12 weeks, there's still antidepressant response. So there's sustainability in a lot of these subjects after receiving only a single dose of psilocybin. Some studies use multiple doses, and I'll hopefully draw our attention to that as we go through it. So this was the first study, came out in 2022, New England Journal of Medicine, a huge journal in our field or across all of medicine. So made a major splash. And a year later, the subsequent trial came out from the competing company, USONA, and another double-blind controlled trial, but this time they used niacin. And niacin is a B vitamin. What it does is really induces kind of a subjective flushing response. And sometimes people, when they receive psilocybin, they can get hot, as I talked about, the sympathomimetic response. I don't think it's a great placebo, but it's, this is something that the field has struggled with, and hopefully one of the things that we're advancing the field with. So, but just mind you, this is a niacin, it's not an inert placebo. So again, the demographics here, a smaller study than the last one, about 100 subjects, but pretty similar. The other thing I want to draw your attention to, it's predominantly, in all the studies I'm going to show, predominantly Caucasian populations, higher SES. If you look here, 50% of the subjects were making greater than $100,000 annually. That's not typical of major depressive disorder with its high disability, but it's in research studies, it tends to be a self-selecting population in a lot of ways. And oftentimes these people are able to get better medical care, which a lot of times medical comorbidities are exclusions. So unfortunately, this is, the population that we're treating as a non-representative sample, but, take it as you will, but they still have severe depression. They've had many failed treatments previously. And as you can see, a similar study design here. There was this time a shorter study, went out to 43 weeks, so about 6 weeks. But again, there was almost immediate separation between the niacin group and the psilocybin group, where there was a very little, if any, response in the niacin group, and the psilocybin group had a very dramatic response as soon as day 8, and they sustained it. Again, single dose out to day 43 with extensive psychotherapy throughout that period. These are the individual ratings in the bottom. You see there's the majority of the patients had a very dramatic antidepressant response based on changes in MADRS. That's clustered here. You see the mean is, from about 35 to 16, 17. It's hard to say exactly what number that is. Whereas niacin, there was very little change. And when you go out to day 43 at the end of the study, a clear separation between the psilocybin and the niacin group. Out to from baseline to day 43. So 2 large studies that have shown psilocybin having greater antidepressant response than various placebos. Just to draw your attention here, this is not a very typical placebo response in a clinical trial for depression. Oftentimes drugs don't reach approval because they don't demonstrate antidepressant efficacy, but they fail to separate from placebo. And because the placebo responses can be very great in major depressive disorder, as well as other psychiatric conditions. So most patients here knew they were getting niacin. Most patients here knew they were getting psilocybin. So what we call expectancy biases or functional unblinding is a major factor in any psychedelic clinical trial to date, and is also a major factor in ketamine trials as well. So if you go back to my past presentation, you'll hear me talk about that at length as well, about the inadequacy of our current placebo. Okay, so this is bipolar depression. This was an open label trial, so no placebo here. Everybody knew they were getting psilocybin, and this was using the Compass compound, that COMP360. It's a smaller study, 15 subjects here. Harder to recruit, and a lot of patients, the other thing too I didn't mention is these patients are unmedicated. So a lot of patients with bipolar disorder, maybe a little bit more bipolar 2 certainly than bipolar 1, but have difficulty being or are able to be off medications for an extended period of time without having destabilization of their illness. So that's also part of the reason why some of the bipolar trials might have smaller ends than the major depressive disorder trials. But pretty similar panels you're seeing, a severity in the 30s, almost immediate antidepressant response. So this time they used MADRS here, as well as QIDS SR, and that's a self-report, quick inventory of depressive symptomatology. So the patients also felt like they were getting better very quickly. Very dramatic response in suicidal thinking, using this Columbia Severity Suicide Rating Scale, going from a relatively high score to having little, if any, suicidal thinking by the time that they received psilocybin. And what's also great here is, unlike some of the treatments that I mentioned before, typical antidepressants, SSRIs, SNRIs, et cetera, there was a almost immediate subjective improvement in quality of life. So people felt like this was a great experience for them, and it also had functional consequences. In my experience with administering psilocybin, again, to a handful of subjects, still pretty new to me, but people consider it one of the most profound experiences of their life. So I think the importance of it, of the experience with the guided psychotherapy, can't be minimized here as well. And this is pretty interesting. So looking at the intensity of the experience. So on the x-axis here, they're looking at this altered dimensional altered states of consciousness questionnaire, where a high score indicates greater altered consciousness, so a more intense or more mystical, more important experience for the subjects. And those patients who had a greater mystical or intense experience tended to have a better antidepressant response. So again, a testament to the importance of the experience of receiving psilocybin itself. Okay, I'm going to talk about 2 alcohol studies, and then I'll talk about our studies. So the 2 alcohol studies were conducted both at NYU. Different outcome measures, as you could imagine, but the first study was an open label proof of concept feasibility study, which is basically what we were doing too. It was 10 alcohol dependent patients. They received either 1 or 2 oral doses of psilocybin. These were weight-based, unlike the things you've seen previously, so they could have gotten higher doses of psilocybin than they received in the MDD trials or the bipolar disorder trial. So 0.3 milligram per kilogram by weight, or 0.4 milligram per kilogram, and they got 2 doses of that higher dose. But they also combined it with motivational enhancement therapy, in addition to this assisted psychotherapy that they received during the psilocybin sessions themselves. Okay, so the outcomes here were percentage of drinking days and percentage of a heavy drinking day. So heavy drinking days are usually defined by 4 or more drinks in a single sitting for a male, and 3 or more drinks in a single sitting for a female. And you can see there's percentage drinking, percent heavy drinking days, was pretty high at baseline. The subjects were monitored for for a period of 4 weeks, just to see if being in the monitoring itself would affect their drinking behavior. It did have some modest effect, but then they received psilocybin at week 4, and you can see a dramatic decrease in both the percentage of heavy drinking days as well as drinking days. And I mentioned before about effect sizes. That's indicated here with this Cohen's D. So an effect size is a marker of how strong the drug works, basically. So an effect size anywhere from about 0.3 to 0.8 would be considered a moderate effect size. Anything above 0.8, which you're seeing many of these greater than 1, would be considered a large effect. So psilocybin had a large effect in this small sample, and most of these drinking parameters at various days. And the other thing that, just for safety, and these are things we're doing as well, we're monitoring blood pressure, monitoring pulse. They didn't see any change in either the systolic or diastolic pressure during the sessions themselves. And that you're also looking at the intensity of the experience, so how this deviates from reality and how quickly they return back to what would be considered their baseline mental state, so how quickly they cleared the mystical experience. And you can see there's a clear peak, about 120 minutes or so, 180 minutes, and that by the end of the session, 360 minutes, by the end of the day, people were approaching their baseline. So they were high for a period of time, and then they came back down within the sessions themselves. Okay. So the second study was a larger trial, more pivotal. It was in a higher impact journal, JAMA Psychiatry. And again, they used another placebo here. So diphenhydramine is Benadryl, and Benadryl will induce some sedation, can kind of clear up your breathing a little bit. Some people report that they're able to breathe more clearly with psilocybin. So the antihistaminergic effects of diphenhydramine might also serve as a placebo that's better masked than certainly just an inert pill or a sugar pill. But again, they use pretty high doses here, so 25 milligrams per 70 kilograms, or even higher doses, 25 milligrams to 40 milligrams for every 40 milligrams, and then use a higher dose of diphenhydramine, depending upon the subject's experience with it previously. And demographics here, again, pretty similar to what we've seen, relatively high proportion of patients who are non Hispanic, Caucasian, pretty heavy percentage of drinking days. So in the past month, majority of patients had significant number of drinking days, and then heavy drinking days as well. You see what they're drinking per day. You can look at that later on as you like. So again, they got 2 doses here. The arrows are indicated by the doses. So at percent heavy drinking days, and up here, percent drinking days and drinks per day. And you can see there's diphenhydramine had a pretty potent response too here. So this is a better placebo than I expected it to be based on the study. Yet psilocybin still separated on all these drinking measures: percent heavy drinking days, percentage of drinking days total, number of drinks per day. So it had a positive response relative to diphenhydramine on all these outcomes. So that being said, this is a better placebo, and I think you're seeing, the psilocybin, from what I've described, and maybe based on people's knowledge and even personal experience with the drug, compared to Benadryl, it's still not going to be a great placebo. So one of the things that we've struggled with in the field is these expectancy biases, how to best maintain the blind. And our group had the idea of using another hallucinogenic compound, and that compound being one that I have particular experience with is ketamine. So I'll talk a little bit about ketamine and kind of what we're doing with ketamine, because I think that head-to-head comparison might have the best ability to maintain a blind compared to these other strategies that have been tested thus far. So, okay, so ketamine, again, I gave a whole talk on this previously, but it's a synthetic derivative of phencyclidine, or PCP, which is also a synthetic compound. These are glutamate antagonists, so they're N-methyl aspartate, a subtype of the glutamate receptor. So they bind to these receptors and they prevent the normal agonist or glutamate from binding. Yet it has very complex mechanisms. So I think of it more as a glutamate modulator. It can actually enhance glutamate secretion in certain parts of the brain. That's been shown to be very important for its antidepressant response and something my group studies. So it's not as simple as just blocking the receptor, but at high, and it has off-target effects. It can affect dopamine, can affect acetylcholine, can affect opiates. This has been, there's several papers now looking at the ability of naltrexone to block ketamine's antidepressant response. Is still highly controversial, but it's an interesting topic. And in toxicology, similar to, looks pretty similar to psilocybin, actually. So high doses can cause dissociation, psychosis, high blood pressure, pulse, can very uniquely cause urinary problems. So people who abuse ketamine can have urinary cystitis, which is unfortunately long-term and not reversible. And it's rarely lethal in isolation. So it's oftentimes used as an anesthetic, which is right now for racemic ketamine, the IV form, it's only FDA approval. I mean, people use it for a lot of different things. There's, including ourselves, IV ketamine for the treatment of major depressive disorder. I don't know if it's actually been fully approved yet, but I've heard it's being approved for pain disorders as well. So there might be a second FDA approval besides its approval as an anesthetic. But as of my recent review, it's still Schedule 3 with only FDA approval as a dissociative anesthetic in operating rooms. So we have two trials that we're running similar to what the Bogenschutz group did. So comparing ketamine-assisted versus psilocybin-assisted psychotherapy for alcohol use disorder. A lot of acronyms there, but you'll see that a bunch: PAP versus KAP-AUD. And the way we've kind of identified these two studies is 1.0 and 2.0. So we'll talk about 1.0 first. We're almost done with 1.0. We have one patient who's finishing up the trial. So I don't have any data to present, unfortunately. We have to wait until all subjects have completed, but I'll talk about its design and how what we learned from the performance influenced our ability to design this larger study. So first thing we were doing is feasibility, and any new site, new trial, new drugs. For us, we want to determine that we can enroll subjects, people aren't dropping out, there's not any unanticipated adverse events, and they're overall satisfied with their experience as well as with the clinical team. So, but the things we used were similar to what Bogenschutz's group used: the alcohol timeline follow back that will assess percentage of drinking days, percentage of heavy drinking days. We're also going to be looking at alcohol craving. A lot of treatments can affect alcohol craving, for example, naltrexone, and to date, nobody's really has reported on that. And also its ability to potentially affect laboratory measures. So if somebody has abnormal liver function tests, they are sober for a period of time. In this trial, it was 8 weeks. So if they're sober for 8 weeks, how does that affect their LFTs? The thing that we're also adding to is, and Peg Napolis, who's the co-PI with me on the study, and myself have expertise in neuroimaging. So we're doing a bunch of different neuroimaging parameters. We're looking at resting state, functional magnetic resonance imaging. There's a form of acid-base sensing MRI that we use here called T1-RO. We're looking at brain metabolites, so glutamate, GABA, looking via magnetic resonance spectroscopy, and then also looking at white matter integrity in the brain with diffusion tensor imaging, or DTI. So this will be after the subjects receive the drug as well as before. So baseline versus after, see if we see changes in these various neuroimaging parameters. So similar to what we saw previously, this was a pilot study, 10 subjects. We initially only recruited males. The initial desire for that was to kind of eliminate potential for any neuroimaging parameter differences. There's big differences based on sex in a small study. So if we recruited either one gender or the other, we thought we might eliminate one potential large variable in a small neuroimaging study. Pretty restricted ages, 25 to 50, 50 to 150 kilograms, and that's also limited by the scanner. The bore of the scanner, we're using a 7T scanner, which is a narrower bore. They have to meet a diagnostic and statistical manual criteria for an alcohol use disorder. They can't have undergone any alcohol use disorder treatment. They can't have had any other substance use disorders in the past year. Can't have any prescription or illicit drug misuse in the past 3 months, and they have to be off psychiatric meds. So the concern with the psychiatric medications is that they can affect the ability of psilocybin and or ketamine to exert their, in this case, anti-alcohol effects. Serotonin, glutamate, many of these medications work on those pathways as well. And these are just various other parameters. So basically have to be medically healthy. They can't have tried these drugs in the past, and they can't have great risk for psychosis. So if a personal family history of psychosis would be an exclusion. So okay. And this is what we had 2 phases of the study. So there's the randomized controlled timeline and the open label extension. In this study, if somebody was randomized to ketamine, they were given the opportunity to receive psilocybin in the open label extension phase. But you see just kind of very globally here how important therapy is to this process. So there's preparation phases, there's various calls for ratings, and then only after that occurs do the patients receive the drug. So they're randomized. In this case, it was a 1-to-1 randomization. So 5 subjects received psilocybin, 5 subjects received ketamine. Obviously, that's why we haven't looked at the data yet, because the blind has not been broken, so we don't know who's in which group yet. Then they received continued psychotherapy, week 3, week 4, rating scales, and then a follow-up here. And the image parts with the brain were places where we did neuroimaging. So before, the day after, and then at the end of the study. So you see it's an 8-week study, and many moving parts, including our clinical research unit. So the nurses are intimately involved, checking vitals, administering the drugs. But the administration sessions themselves are in a very private room. The subjects are oftentimes have a playlist that is predetermined that they listen to during the drug session, and they have 2 therapists in there during the administration and guiding them through the sessions themselves. So the doses that we used here were 25 milligrams. We're using the Usona compound based out of affiliated with the University of Wisconsin-Madison. The difference with that we don't have so ketamine, we're actually using the IV preparation but diluting it in a syringe with or not diluting it, I'm sorry, 200 milligrams in the syringe with kind of an amber color. So there's slight differences in the color between saline and racemic ketamine solution, so people aren't able to tell. Unfortunately, ketamine is not very orally bioavailable. So 200 milligrams sounds like a pretty big dose if anybody has experience with ketamine, but it's only about 20 to 30% bioavailable. So most subjects are going to absorb about 20 or 30 milligrams. So it's a relatively low dose of ketamine compared to what is oftentimes used in depression studies, where people might get up to 1.0 milligram per kilogram, so 50 milligrams, even higher doses. So that's something we learned from the study, that sometimes the experiences with what we thought with ketamine could be pretty short. And again, if subjects were randomized to ketamine, they were given the opportunity to receive an open label psilocybin in this second half. So everybody knew they were getting psilocybin here. And we did, again, repeated therapy, repeated ratings, and looking at how people responded in that open label extension if they received ketamine for their first dose. So again, we're almost done with this study. Our based on what people have told us, we're assessing for expectancy. Do they think they were randomized to ketamine? Do they think they were randomized to psilocybin? And we're seeing, a mixed bag. Most people are saying that they think they were randomized to psilocybin as their first drug administration, and obviously that can't be true because several of those patients were subsequently randomized to ketamine, and then they've received psilocybin. So we're hoping this does a much better job with blinding than we've seen in the field thus far with various other strategies. Okay, so we've actually started the second phase of the study, so 2.0. The things that we're changing here, so we're moving to an intramuscular injection of ketamine. So this is much more bioavailable, 100% bioavailability, higher dose as well. So we think it'll better mimic what people see with psilocybin. And based on our safety data and experiences, we think a higher dose of psilocybin is warranted here, consistent with what was seen in the Bogenschutz study, where they went up to higher doses. And we're going to be doing now, or we have not dosed anybody yet, but we'll soon be starting with a dose. I think actually our first is next week. So either 30 milligrams of psilocybin or 0.75 milligrams per kilogram IM. And we're doing what's called double dummy here. So if you're randomized to ketamine, you're going to get an IM shot of a placebo or saline. And if you're randomized to psilocybin, I'm sorry, if you're randomized to whatever way I said it, so either an oral placebo or a saline intramuscular injectable placebo, and you get both at the start of the study. And then there's a longer follow-up period here, so we're looking to see how sustainable this response is beyond 8 weeks. And then we're going to be doing several additional biomarker assessments, which I'll talk about in the next slide, I think. So same drinking behavior outcomes, alcohol timeline follow back to look at percent drinking days, heavy drinking days, craving scale. So some of the things that we're adding here, these are various markers in the field that have been proposed as more sensitive and specific indicators of alcohol misuse. So phosphatidylethanol or PEth, and then carbohydrate deficient transferrin or CDT. They're actually highly sensitive for the amount of alcohol consumed in the past 30 days, which is pretty unique. And then we're also going to be looking at various epigenetic markers, and that's in collaboration with Rob Philibert's group, who studies the epigenetics or the gene by environment experiences of consuming alcohol. And the imaging physiology is overall pretty similar, but the one thing that we're adding is an EEG or electroencephalogram during the administration of the drug itself to try to capture brain differences that might be experienced with psilocybin or ketamine during the drug administration with the assisted psychotherapy. So there's going to be what we call a mobile or dry cap EEG placed on the subjects for a short period of time during the drug administration. We also worry about it affecting their experience, so we don't want to do it for too long. So we're trying to find a medium path there without interfering with the experience of the drug itself. So things that have changed here. So we're a much larger sample. We're recruiting women now, so all genders. The expanded age group, 25 to 65 years old. And as opposed to DSM-5, we've expanded this to this WHO medium risk drinking. So this should be a more inclusive criteria. So for a male, an average of greater than 21 standard drinks per week in the previous month. And for a female, an average of greater than or equal to 10 standard drinks in the previous month. We wound up excluding a lot of subjects for prior use of hallucinogens and or ketamine. So we've limited that to the past 3 months. But everything else looks pretty similar to the 1.0 criteria. So, and you see it's a longer study, so there's more visits. Still the importance of psychotherapy. So there's this, phase 1 where we're screening, enrolling, providing therapy, providing the drug. Again, a lot of preparation before people even receive the drug. So there's several weeks before they receive the either ketamine or psilocybin. Extensive post drug administration processing and discussion about their experiences. And then various, again, video or in-person therapy in this phase 2 with a 3-month follow-up period. And then at visit 12, this will be their final visit. So here there's 2 days where we're doing neuroimaging, so baseline, and then at the end of the trial, and then the intervention will be complete after 16 weeks. And again, if they so desire, they can participate in this open label extension. So if you received psilocybin, you would get ketamine and vice versa. The open label extension is a shorter period than last study, but pretty similar, and we're going to be looking at the same outcomes. So if somebody did not respond well to ketamine, how did they respond to psilocybin and vice versa? Okay, so hopefully I'm doing pretty good with time to leave some time for questions. So this are the conclusions, kind of take-home points from my presentation. So like LSD, psilocybin is a classical psychedelic. So again, they're all 5-HT2A agonists. So they bind to that receptor and they activate it. That's what an agonist means. In contrast to other drugs with hallucinogenic potential, for example, phencyclidine or PCP and ketamine, which we've talked about. So we're really excited to see how the drugs differ on a lot of these measures and also get a better sense of how well we can blind. And although it remains purely research, so there's no current treatment indication, again, psilocybin is still Schedule 1. It's been decriminalized and legalized in several states. It's not legal in the state of Iowa. But psilocybin has promise for the treatment of several psychiatric disorders, including major depressive disorder, bipolar disorder, and alcohol use disorder, certainly not limited to those. And as randomized clinical trials of psychedelics, hallucinogens have been hampered by functional unblinding or expectancy biases. We're proposing that head-to-head comparisons may better maintain blinding and limit those expectancy biases where again, people find the mystical experience of psilocybin to be really tantamount to its therapeutic response. And if we have a better blind, we can better control for that. So, all right, so acknowledgements here. So I want to thank we have philanthropic funding to conduct the study currently. We're applying for NIH funding soon. So thank the Scanlon Family Foundation, which has been instrumental in getting us going and supporting our investigations to date. So as I mentioned, the other co-PI here is Peg Napolis, who's the chair of the department, myself, and then Alistair Wilton is co-boarded in internal medicine, in psychiatry as well as addiction medicine. So having his expertise has been very important, and he's over at the VA, and we're trying to. The Scanlon family is particularly sensitive to VA affected disorders that affect the VA population. So we're trying our best to recruit as many veterans as possible. The 2 therapists that we have currently, Rebecca Stinson and Ann Ventullo, and then our administrative research support, Erin Golden and Lindsay Fuhrmeister. And I want to thank Erin in particular because she really helped me prepare a lot of these slides, especially all the timeline slides. Those were really totally hers that I had the opportunity to gently revise. So if anybody is interested in learning more about the study, including potential participation for themselves, for family, for friends, whoever, please feel free to email Lindsay. Her email address is there. She's going to be forwarding you to what's called a REDCap survey, and you can complete that survey. And theoretically, you can complete it for a family member as well, but obviously they need to consent to the protocol. So we'd encourage you to reach out to Aaron to discuss potential participation. So, and that's it. So thank you for all your attention, and I'm happy to stay as long as you like for questioning.
I do. This is Barcy Levy. I'm a family physician at the university, and I had 2 questions. One is, due to your criteria for letting people into the alcohol studies where they can't be on any, sounds like they can't be on any psychotropics, has that been a major barrier, or I would think most people with alcohol use disorder might be on an antidepressant or some other form of psychiatric medication.
Yeah. So for 1.0, and we have a slide I didn't show here where the major reason for exclusion from the REDCap surveys was for concomitant medications. So mostly, as you mentioned, appropriately, the high comorbidity between depression, alcohol use disorder. It was a major, I'd say probably 75% of the failed screens were due to patients taking antidepressants. Sometimes people know that they're not eligible for the study if they take an antidepressant, so they decide to take themselves off their antidepressants, sometimes without the knowledge of their family physician or other prescriber. So we've had patients do that. We're not encouraging anybody to do that. And then they've contacted us. They said, well, I saw you have to be off this medication for 3 months. I stopped my escitalopram in February, wanting to do the study. So can you consider me now? But it's a major concern in the field overall, not even just with alcohol, but with depression too. So all the depression studies, people are unmedicated. And as you can imagine how challenging that would be, because these meds are mostly serotonergic. Psychedelics, the classical psychedelics are serotonergic as well. And we're not actively tapering people off their meds. So it's a major problem. Said there was a second too.
So for some of the studies, you keep people on their antidepressants?
Well, we do not, but other places
Okay.
have done that. So Johns Hopkins, which has a very active psychedelic research center, is actually probably one of the best in the world. Roland Griffin was, instrumental in starting that, and recently deceased. But they have several studies ongoing for depression where they're keeping people on their meds and seeing if that affects the psychedelic experience.
Okay. And then the other question was, have you used these, or are there any studies going on for schizophreniform disorders or schizophrenia?
I'm not aware of any, and I think, I would be really concerned about people with a history of psychosis receiving any of these drugs, including ketamine, for the treatment of schizophreniform, schizophrenia, schizoaffective disorders. So the closest that has been, to my knowledge, with ketamine has been with major depressive disorder with psychotic features. And in some of those trials, small studies, it didn't show that it worsened psychosis. But basically every study I know that looks at psilocybin, including these larger industry-sponsored studies, excluded for psychosis, history of psychosis. And many of them, like we did, exclude even for a family history of psychotic spectrum illness.
Okay, thank you.
Sure. Yeah. Thanks for good questions. Thanks.
Yeah, very good question.
Hi. Hope you guys can hear me.
Yep.
I read a few studies that suggested that SSRIs don't SSRIs negatively impacting the efficacy of psilocybin. Is that just what we believe based on the mechanisms, or has that been observed directly in studies? And I only ask because I've seen a few double-blind placebo-controlled studies where they did psilocybin versus psilocybin with SSRIs and did not see it diminished.
Yeah, there have been a few studies, as you correctly noted. It's more mechanistic. So, both, affecting levels of serotonin synaptically. I think the real concern is that an excessive amount of serotonin. I don't think anybody's ever seen serotonin syndrome, which is a serotonin-based toxidrome. So having too much serotonin, but that's one of the major concerns, is that if somebody's on an SSRI, that they could, and with the addition of a 5-HT2A agonist, so something that's going to stimulate the receptor, plus having increased levels of synaptic serotonin, that it can lead to an uncontrolled experience. As you noted, there have been several studies that, to date, small studies, that have not shown that it worsens the psychedelic experience or it affects the ultimate outcome. But I think it's still, they're small studies, and hopefully I know of a big one coming out from Hopkins. So I think that will, because if that shows a lack of interaction between the two, I think it will really open up for a lot of patients, especially if these drugs ever reach market, right? I mean, we're not going to ask everybody to come in and taper off their antidepressants in anticipation of receiving a one-time dose of psilocybin. I mean, it's not really practical or safe, potentially. So
I have a question about comorbidity or the other diseases that the people in the alcohol use disorder completed study had. And also maybe you could just speak to the efficacy of having such a small study and kind of, it seems like a lot of work for 10 folks.
yeah, yep. So I think it's both very good questions. So we started with a really stringent criteria, and over time, this was part of the learning experience for us, and that we had to kind of broaden our scope. We couldn't exclude for patients who have comorbid depressive symptoms, for example, which in my experience screening, the majority of the subjects, most patients meet criteria for a major depressive episode. You know, you could argue whether that's major depressive disorder or it's a substance-induced mood disorder. And I think in most patients I've seen, I would probably characterize it as an alcohol-based mood disorder. So their consumption of alcohol at very high levels, being a potent depressogenic compound, is inducing symptoms consistent with major depressive episode. And if they stop drinking, hopefully the subjects would have resolution. But we don't exclude for that, and that's been the most common comorbidity. The other comorbidities, as you could imagine, are very higher anxiety disorders. So we don't exclude for any of those either. So generalized anxiety disorder, we've had a lot of veterans, post-traumatic stress disorder. Those are all things that we've allowed. So really the only disorders that we've excluded for are other active substance use disorders. So if somebody has even a cannabis use disorder, they'll be excluded. But obviously, if they were abusing other substances, psychostimulants, methamphetamine, other opiates, they would not be eligible for the study. And then psychotic spectrum disorders. So if somebody's had a history of like bipolar disorder with psychotic features, or a history of schizophrenia, or those patients are. They're not really even screening for the study. I think we have not had many screen fails for that purpose. I think it hasn't even reached that level. But at first we were excluding for subjects who had extensive depressive symptoms, and we realized we couldn't recruit. We couldn't really recruit because that's such a high comorbidity. And then the second question is about the resources, and there's a lot of resources that were invested. Thankfully, Peg, as the chair of the department, can control some of those resources. And but the Scanlon Foundation has been really, I mean, they're dedicated to improving mental health outcomes, and they're particularly interested in psychedelics. So this study would not have been possible without them, even the 10 subjects. And this was really our first foray in psychedelics. There's no other psychedelic studies using psilocybin, to my knowledge, in the state of Iowa. I'm the only one who has a Schedule 1 DEA. So I'm the only one who can actually prescribe psilocybin in the state of Iowa, if in a research setting. So it was several years coming, and now I think we put our time and effort in, and we're hitting stride. We're screening subjects at about 1 to 2 per week, and hopefully getting those 80 subjects within the next 3 to 5 years. I think that's the goal. So but we're hoping this could be very important for demonstrating blinding, because if the MDMA lack of approval for PTSD, one of the major concerns that the FDA had was functional unblinding, that every subject who received MDMA knew they were getting MDMA. They had a high expectancy of resolution of their symptoms with MDMA, and comparing it to a saline placebo is just inadequate. It's, you might as well just do an open label study.
Sure. No, I appreciate the information, and it's just great to see something even small that's head to head.
Yeah.
So thank you.
Yeah, sure. Yeah, that's great. Thank you.
Do you guide the patients through their psychedelic experience, and are there different methods for therapy while they're under the psilocybin or ketamine?
So the first question is, do I do it, or do we do it?
are there different methods
Yeah,
to
yeah, sure,
guide
sure. Okay,
the
yep, yep.
patients?
Yeah, so there's no standardized manuals out there. So there's several kind of expert-based guidelines or principles. So Hopkins, I say, is probably, again, the leader in this. They have a very well-developed guide book, and another one that we used in our creating our sessions or guiding our therapists was from Yale. Thankfully, still my connections there, I was able to get access to their guidance. But a lot of this is really just being done in the community by experienced psychotherapists. So the person that we had on board who's recently retired, many of you might know, Candida Maurer, she has extensive experience with psychedelic psychotherapy, has went to various training programs, including programs, and she openly talks about it, about her own experiences with psilocybin, ketamine, other ayahuasca. There's other compounds that there is part of the training. So there's a lot of non-academic training programs and experience guided programs that I think started really in the 60s, right? So this tradition stemmed out of psychedelic culture of the 1960s, and unfortunately hit roadblocks in the late 70s, early 80s with say no to drugs, and the kind of hard line again against the use of any illicit substances, even for therapeutic purposes. But of course, that there's still a lot of people interested in it, and this was really a resurgence, I think, once the people who are the boomers are now in the position of power. So now we're seeing these resurgence of these things, since people who grew up with that culture are now controlling the resources and can allocate those resources. So that's why I think we're really seeing a big resurgence with psychedelics and other quote unquote illicit compounds. But the training manuals, yeah, just to I know I'm getting off topic, but the training manuals are very much idiosyncratic. There's no one road to Rome, I think.
Have you considered functional MRI studies just to see what parts of the brain are getting more glucose or more of whatever the nuclear medicine
Yeah.
scan
So
would be
we're
located?
doing those.
And also, how do you explain the spiritual part of it? Is there a theory about what is happening here? I know we're really trying to see the efficacy, but are there some theories about why it works so well?
Mhm.
And could
Yeah.
that be helped by functional MRI?
Yeah. So there have been a lot, and we're doing this. There has been a lot of functional MRI and other neuroimaging studies, including some really pivotal studies that have been published in the highest caliber journals like Nature. One of the primary hypotheses about what's happening is that there's kind of a desynchronization, or kind of a softening, for lack of a better term, of some of brain connectivity that becomes more plastic and receptive to receiving novel stimuli. And when these novel stimuli are coming in or being activated in the context of the psychedelic experience, it's kind of a resurgence of pathways that have been more closed. So that's been shown in a few different ways with functional imaging, but nobody has really done functional imaging during the drug session themselves. People have done EEG like we're proposing to do, but nobody has done MRI, and it's getting psilocybin while you're in the scanner, which is probably something that should be done at some point, but I think it's has not been done to date.
Thank you very much, Mark. Obviously,
sure.
there's a lot of interest in this topic.
Yeah. And I really appreciate you having me again. And if anybody would like to, please feel free to reach out. I'll be happy to.
And we have recorded this, so this is going to be available probably in a week or so on our YouTube channel, where we keep all of our lunch and learns. So thank you so much. Thanks to all of you for coming,
Sure.
and we'll see you next month.
Awesome. Thanks, everybody.
Take care.